Let's talk a little bit about ligament issues. So usually, it can happen that you have, you just dislocate your elbow, but in a lot of cases, it's going to be, potential fractures and ligament issues all at the same time. So when it comes to ligaments, I'm going to divide it into LCL, so the lateral collateral ligaments, and then the MCL/LCL. And then the MCL. All right, so let me dive into the list of ligaments for you that are key indicators, right? So when it comes to ligaments, you have the MCL, the medial collateral ligament complex. So in this, you have the anterior oblique. Let me write it out. You have the anterior oblique. You have the posterior oblique. And then you have the transverse. This right here is the most important, the anterior oblique. This is the most important, so it's a complex. So the medial collateral ligament, if you think about it, it's over here, right? The medial side, medial collateral ligament, and this whole complex breaks down into the anterior oblique, the posterior oblique, and the transverse. But the anterior oblique is the most important stabilizer to valgus, right? It's the most important piece of ligament that's important to stabilize towards valgus. Now it says that the anterior band is tight in 0 to 60 degrees, and then the posterior band is tight between 60 and 120. I think the most important part is to know where this generally is located, and the anterior oblique being the most important component, right? And then now you have your lateral collateral ligament complex. And so your lateral collateral ligament complex, you have a lateral radial collateral piece, right? Then you have a lateral ulna collateral ligament, which is also called your LUCL. You have your annular, you have your accessory. The lateral collateral ligament has a bunch of pieces, and the most important one that we want to pay attention to is the lateral collateral ligament. All right, that's the most important one out of all of them. But this annular guy stabilizes the radial head, right? These are just details. So if there's a random general knowledge, which one is it, you can rule in and rule out, right? But for the most part, if you're looking at elbow injuries and ligament injuries, you just have to chunk them into lateral collateral, medial collateral, and when you damage the both of them, it really sucks. If you injure the lateral collateral ligament, then you need to be in pronation. This is pronated, right? So let's say you broke a bone and you tore that set of ligaments, then you have to stabilize for the fracture, right? But it tells you literally you're allowed to move. But the thing is, you have to move with that forearm in pronation, forearm position, right? So in a lateral collateral ligament, the forearm is pronated if there's an LCL tear or repair. And so you want to avoid internal. So that injury is over here. So it's the lateral collateral ligament. So it's just telling you, if you tear this here or it needs to be repaired, you need to avoid internal rotation, right? Why? Because if you go internal rotation, it's going to put a lot of stress and pressure onto the lateral collateral ligament, right? If we're talking about valgus and varus, right? Varus. Damn it, I'm still putting a damn G in the word. Varus, then you want to protect it from being pushed. Like, so if you're taking a look at this chunk of forearm right here, you don't want this forearm being pushed into your body, because it's going to put pressure on this area that was torn or had surgery, right? So that is the lateral collateral ligament. And then if you had a medial collateral ligament, then your forearm needs to be in supination, and you want to avoid external rotation of the shoulder, right? So if your medial collateral ligament injury is over here, you want to avoid external rotation, because if you go into external rotation, you're going to put pressure onto this area where it is it's going to apply pressure, right? So you also want to avoid valgus motions or activities, because if you're not supposed to go into external rotation, because it's going to put pressure. If you're taking this forearm and you're pulling it into external, it's going to put pressure here. So on an exam, it's going to potentially give you an activity that says, oh, well, what would you do? What activity, blah, blah, blah. You're gonna need to understand those key concepts and those key words, right? Because it's not gonna be like, oh, which ligament per se, but it's gonna be like, if they had a fracture and they had a medial collateral tear, what's the forearm positioned in for how long, blah, blah, I don't know. They're gonna put some shit together for you, right? Or they might compound that and say, okay, this is the story, blah, 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 and what kind of activities would they potentially do? But this is the same kind of thinking that you would have when a patient came in, right? So why put into a certain position? Now, if you tear both or you repair both, then you need to be in neutral, right? You need to be in neutral. And you want to avoid internal rotation and external rotation, because they're both torn. You can only go like this, right? You can't do any fancy stuff. So you want to avoid varus and valgus motion altogether.